Morning, doctor. I don't think we've had the pleasure of meeting. Welcome.
Thank you.
Sir, can you just describe, you started to do it a little bit on direct, a typical day for you?
I wake up at 4:15 in the morning. I go to my center. I set up patients with frames for their either radiosurgical procedures or stereotactic craniotomies. I go home. I make cappuccino for my wife at 6 o'clock in the morning. And then I get back to work at 6:30 and move on. I have patients that I'm operating on, and I have patients that I'm seeing through the day.
And what type of patients and what type of work? Just in a typical day. What are you doing? What type of patients and what do you do?
It varies. I mean, I see patients with brain tumors. I see patients with hydrocephalus, which is water in their brain. I see pediatric brain tumors. I see subacute and chronic subdural hematomas, post-traumatic. I see patients with strokes that are being misdiagnosed. I see patients with cancer, metastatic disease. I used to see patients with cervical problems. I stopped doing that 2 years ago. I don't know what else you want me to tell you.
No, that's great. And is that typical day, typical of the type of days you've had for the past month, past few years? Is it generally, without specifics, is it generally?
Correct.
So, none of your typical days, none of the past typical months have involved forensic pathology, have they? You haven't acted as a forensic pathologist in...
I am, if you could have asked that question, very straightforward. I am not a forensic pathologist. I'm a brain surgeon.
Right. And you don't perform autopsies, correct, sir? You're a brain surgeon.
Correct. In other words, I see more brains than the forensic pathologist.
Right. And is it correct to say that the brains that you see are of living people?
Correct.
Okay. So what I'd like to do is to go to a different part of the head than was discussed, but sticking with the decedent.
Excuse me, I didn't hear the last one.
I'm sorry, with the topic is going to be Mr. O'Keefe, the decedent in this matter, sir. You testified about raccoon eyes. The medical term for that, sir, is ecchymosis, right?
Correct.
And ecchymosis, raccoon eyes, does not cause a laceration to form on an eyelid, does it?
No.
Are you aware that Mr. O'Keefe had a laceration to the outside area of his right upper eyelid?
I am aware that the ME described that. Yes, sir.
Now, could, Your Honor, I'm going to, with Your Honor's permission, ask to publish what is already in evidence in a moment.
Okay.
Mr. Wolk.
What exhibit number, Mr. Alessi?
We're going to, 165, Your Honor.
Okay. Go right ahead.
Thank you. Dr. Wolf, have you seen this photo depiction before today?
I believe I have.
Is it correct that that injury on the upper right eyelid is caused by the application of force directly to that area of the front of the head, again, namely the upper eyelid?
That's possible, yes.
Is it more than possible? Is it probable that that injury was caused by the application of force directly to that area of the front of his head?
Well, an easy answer to that would be is that that's not part of the periorbital ecchymosis.
Thank you, sir. That was exactly going to be my next question. This injury is unrelated to any of what you've been describing, the fall backwards, the force transfer inside the skull, the, as you described it, the dura, the cerebral spinal fluid, all of that dynamic that you so ably described on your direct examination. This injury has nothing to do with that, correct?
Correct.
Thank you for answering my questions. Dr. Wolf, a pleasure again. No more questions at this time, Your Honor.